or the sub-Q ones. So with this, I think I'll stop here and see if you have any questions.
For those of us with PBC, should we medicate with for osteoporosis or just take calcium and vitamin D?
If you have osteoporosis, yes, we medicate for osteoporosis. It's like the general population, plus you have PVC, which put you at the higher risk population. So if yes, you have the numbers, below a negative 2.5, you're an indication to treat. Now, if you have osteopenia, which is between -1, -2.5, then their argument is if you have PVC, you're at high risk, we should treat, or we use this FRAC score I showed you. If you cross those numbers, we treat. But yes, I would lean towards treating and preventing fractures because you are at PVC is a high-risk population. Well, that's true. There is no case of, it's a bone cancer actually. It's osteosarcoma of the bones. That's with the use of Forteo in rats in the studies. So the risk increase if you have already bone cancer or other sarcoma kind of cancer, and also if you had radiation to the bone. So one, if you have a history of radiation, like many of our patients at MD Anderson do, we do not offer them that option. We tell them there is unknown increased risk of bone cancer, but the numbers, I mean, we don't have a real number. There's no study that showed how much the bone cancer, that could be, it's more an over precaution than the reality that increased risk of bone cancer. Nonetheless, if you had radiation or history of bone cancer or other sarcoma, we don't offer this drug. That's true. Well, if you stop, how long you join the rest of the population? I mean, we don't know. We like to stop as soon as possible. Former smoker at risk, but if you're not a current smoker is what we worry about for continuous bone loss from the smoking habits. Former smoker, if they stopped years back, I mean, could join we don't have numbers how long you should stop to join the normal group. I don't know that. Well, osteoporosis are managed by several specialties, if you want. It could be depending on who's your family doctor, family practitioners. Some of them just deal with it. There's endocrinology, who treat diabetes and thyroid disease, and bone health is part of their specialty. Rheumatologists like me also, we specialize in bone health and we treat osteoporosis. And a lot of OB, GYN doctors, because they do primary care and primary health for women also. Sometimes they have the machine and they deal with osteoporosis. These are the common ones.
All right, next question. I take Prolia injections for my doctor told me to stop calcium supplements. Do you agree?
Well, it depends why he told you, but some patient has other conditions that cause hypercalcemia. We can think about many. But if your calcium is above normal range and you have hypercalcemia, chronic from hyperpara or other diseases, yes, maybe you should not take calcium supplements. But if you are without other conditions, you need the calcium with the Prolia, again, to prevent hypocalcemia. But that's a case by case, depending why they stop it.
Okay, 3 more questions. Is the decrease in OP with PBC patients possibly due to the lower age of diagnosis?
No, I didn't see that. It's, again, the theory is these toxins from bilirubin that's stopping osteoblasts from doing their job, and other theory from deficiency of certain vitamins, but not the early ages. And the third one is because PBC is more common in women and postmenopausal women, that increase to the risk factors. But the early age, we don't know unless you were diagnosed very early, and if the theory of bilirubin toxin suppressing your bone formation is true, perhaps that will be true too.
I've been told that PBC patients don't absorb fat-soluble vitamins. Is that true? If so, how can we meet the dietary goals for ABCK and the calcium we need?
Well, that's another theory why they develop osteoporosis, how to supplement and which vitamins. Perhaps we're going to talk about that in a couple of lectures. So the general recommendations are still from what I read and what I know, is like the general public, it's 1,200 milligram of calcium and the vitamin D we said. Then you monitor. So if you're deficient and you're not picking up, then you change your strategy. Then you think they're not absorbing well. But most do pick up their numbers on vitamin D, and most don't need more calcium. So nothing major difference between the general population and the PBC for the requirement for supplements.
Okay, last one. Exercise physiologist says walking is not very useful for building bone. You need to shock the bone by jumping for most people. Do you agree?
Uh,
If so, what would be? Jump rope, jumping,
No.
skipping?
The recommendations are weight-bearing. Walking is weight-bearing exercise. That's your own weight. That's good. Jumping may be better, more pressure, but not everybody can jump. So walking is considered weight-bearing, and it is beneficial. I wouldn't say stop walking. That's what you do. You keep walking. You need, yes, to put pressure on the bones to stimulate the osteoblast formation. So walking perhaps is not good for your spine. It's very good for your hips. That's why we tell the patient who just walk for exercise also to get maybe 5 pounds and do some stretching on the upper body to pull on these tendons attached to your spine to stimulate your bone to form again. So yeah, walking is good, mostly for the hips. The more you do, the better it is.
This is a appreciation from PBCers for thanking and coming and talking with us.
Great, thank you. Happy to be here.
Thank
very
you.
much.